is 1:30 p.m. and I'm the MCs for today for this CME talk. My name is Angels, and we will dive deep into the first topic from Dr. Toon Dong Hao, which is about shoulder dislocations. Why, when, and how? Fortunately, I never had shoulder dislocation, to now, but I also want to learn more about this topic. Now, without further delay, let's get started, right? It's my pleasure to introduce our expert speaker, which is Dr. Toon Dong Hao from HC Orthopaedic, who will be sharing some of the latest insights and best practices in shoulder dislocations. Why, when, and how. Let's put our hands together. Welcome, Dr. Toon. Hi, Dr. Toon. Very nice.
Hi.
Afternoon.
Hi, good afternoon. Can you guys hear
Yeah.
me?
Yes. Okay. So you'll be sharing the slides.
Yeah. Good afternoon, everyone. Thanks for sacrificing your precious lunch time to join us for this webinar. So I'm Dong Hao from HC Orthopaedic, and I'll be talking about the why, when, and how about shoulder dislocation. So let's get crack on. So from my experience talking to GPs and family doctors, there are a few questions that are commonly asked. For example, why are shoulder dislocations so common among all the other joints? And what should I do in the immediate setting when I see a shoulder dislocation in the clinic? Is there a role for conservative treatment for shoulder dislocation? As well as how are arthroscopic pancart repair performed, which is the most common surgery done for a shoulder dislocation? So my aim of this talk is to help you address all these questions towards the end, but feel free to let me know at any point if you have got any burning questions, right? So first of all, let's go to some definition. So there's a difference between instability of the shoulder as well as a laxity. An instability actually means and there's abnormal symptomatic motion. So the patient usually have a symptom, for example, pain, and it includes a spectrum from dislocation to subluxation. Whereas a laxity is just a normal physiological range of translation within the shoulder joint and is completely asymptomatic. So it's important to know that a joint laxity doesn't always equal to instability, but joint laxity can predispose to it if, for example, the patient sustained a trauma on their shoulder. So the shoulder is the most mobile joint in your whole body. The interesting fact about the shoulder joint is that it's a ball and socket joint, but the socket only covers about a quarter of the surface of the ball. The glenoid, which is the socket, is twice as deep in the superior to inferior direction compared to the anterior to posterior, which means that in theory, it's easier for the ball to dislocate out from the socket from the anterior and posterior direction compared to the top and the bottom. So what confers stability to the shoulder joint? There's a huge list of things that we can talk about. And basically, we just separate them into static and dynamic, where static means is the bone, ligaments, and capsule, whereas dynamic means the muscles surrounding the shoulder. So I'll talk about the glenoid labrum. The labrum is a layer of bumper around the socket, and its purpose is to increase the contact area. So we always talk about the ball and socket joint like a golf ball on a tee. The socket in the shoulder is actually very, very shallow, and it's actually the labrum that deepens the socket up to about 50%, and therefore it confers a lot of stability to the socket. And there are a lot of ligaments that goes across our shoulder joint. The most important is this called the inferior glenohumeral ligament, the IGHL, and its function is demonstrated here in these diagrams. So if you understand what a hammock represents, in the shoulder, when the shoulder is abducted, which means that when the shoulder is elevated, the IGHL actually functions like a hammock, especially in external rotation, which you can see on the bottom of the diagram. So the hammock actually slings across and protect the humeral head from dislocating or coming out from the shoulder joint from the front. So this is a case of shoulder dislocation. It's a 24-year-old, never had a dislocation before, coming with an index dislocation after swimming. So typically, the patient present with shoulder dislocation will have their shoulders in a slight abducted position, and they will have the other arm to support that affected shoulder, and there will be a squaring, which is a flattening of the shoulder contour. So if you do an X-ray, this is what you will see. You will see that the shoulder is anteriorly dislocated based on these AP and lateral views. So the emergent assessment is basically we want to know what are the other structures, for example, the neurovascular status of the arm, and how do you reduce the affected shoulder. So first things, axillary nerve injury is very common, and it's very important for us to assess this before we try to reduce the shoulder. In the literature, it occurs as much as about half of the shoulder dislocation, and this incident increased in those who are over the age of 60. Luckily, most of these are low-grade injury, and therefore a full recovery without intervention is expected. But it's important for you to find out and counsel the patient regarding the progress, which the patient will be able to expect when they are on the path of recovery. There are various ways to reduce a shoulder dislocation. These are from the ancient Greek mythology, when they can range from using a ladder to small kids to try to reduce their shoulder. But essentially, there are three groups of methods that has been described in the contemporary literature. Number one is the traction, counter-traction methods, and that includes your Hippocratic and modified Hippocratic technique. The second group is the so-called the leverage technique, which includes the cockers and the milch. And the last is the others, which include the scapular maneuver as well as the self-adjustment technique, which has been described. So the recent meta-analysis in 2021 showed that there's actually no difference in the success rates between these different reduction maneuvers. And also there's no difference in the complication rates, which some of the leverage methods, such as the cockers, has previously described. Therefore, our advice is that use what you are taught and most comfortable to reduce the shoulder. So this is usually what we do after we reduce the shoulder. We do an X-ray, a radiograph to check that the shoulder is reduced. A lot of times, because the shoulder is in an arm sling, the shoulder will look like a light bulb sign because it's internally rotated. And if the patient has got a very big body habitus, it might be very hard for you to assess on the lateral view as well. So there are some ways that, or some further imaging X-rays that you can take to help you to have a better view whether these shoulders are reduced. And also there's some controversy regarding immobilization, which I'll touch on. So ideally, we want to do a true AP of the shoulder to assess the shoulder joint, not an AP of the thorax, which some of the radiographers do. A true AP takes into account the anteversion of the shoulder, which is about 30 degrees, and it will show you this very, very clear outline that there's a gap between the shoulder humerus and the glenoid, and if there's a gap between the joint, there's no way that the shoulder is out. The other view we can take is axillary view or valpule view. I think in the acute setting, a valpule view is a lot more useful because patient has a lot of pain trying to do axillary view to abduct their shoulder. In terms of immobilization, traditionally we do it in the internal rotation, but there is some patients who are put in external rotation based on some of the studies performed. I'm sure some of the GPs here have seen this external rotation sling called the gunslinger sling before, but the literature showed that there's actually no difference between the immobilization of these methods, and therefore a normal arm sling is actually suffice and gives more comfort to the patient. In terms of duration of immobilization after you reduce the shoulder, the studies show that there's no difference between immobilized in 1 week or immobilized more than 3 weeks. And therefore, immobilization for a longer period doesn't reduce the recurrence rate, and therefore we shouldn't be immobilizing the shoulder for longer than 1 week. Case 2 is a 19-year-old basketball player presents with a recurrent shoulder dislocation. So this is a recurrent problem. The patient on the radiograph, you can see a Hughes-Sachs lesion on the humerus, as well as a bony band cut of the glenoid on close inspection. So in terms of history, it's very important for you to ascertain a few things because that will alter the natural history of the patient. First is the age. The younger the patient has a dislocation, the higher chance of recurrence they will get. In terms of trauma, it's important to know when was the first time they have the dislocation and how many subsequent episodes they have. It's also important to know between these subsequent episodes whether they happen during sports, during impact, during activities, or is it just during normal daily activity, for example, just reaching to the shelf or just when dislocate when they're sleeping, because this would indicate that the shoulder is more unstable and therefore more urgently need to be stabilized. It's also important to ascertain that whether they have any pain when they have the dislocation or subluxation. If it's a painless subluxation or dislocation, like what we show on the video here, then usually this is a muscle patterning problem and must be addressed with the physiotherapy before counseling the patient for any procedures such as a surgery. In terms of examination, we need to check the neurovascular status, like we mentioned. Also check for scapular winging or any generalized ligamentous laxity, such as the Brighton score. We usually do a few laxity tests. So laxity is to check how stable or within the physiological range, how lax the shoulder is. And also we will do instability tests. The most commonly done is apprehension. So apprehension can be done either the patient lying down or sitting up. We recommend not to do by standing behind the patient when you do the apprehension test, because a lot of times I've got 2 residents who have dislocated the shoulder by doing apprehension test this way. So the safest way to do it is to stand in front of the patient. You can do it lying or standing. You do the apprehension, which is the abduction and external rotation, and you have your other hand putting right in front of the humerus to feel when the patient is going to dislocate, and you can do a relocation test straight away. When do we need further imaging? So the gold standard is to do an MRI arthrogram. The reason we want to add an arthrogram to the MRI is to allow us to visualize the intra-articular structures, such as the labrum, which is usually damaged during a dislocation. In the acute setting, when there's a hematrosis, for example, within a few days of the dislocation, there's no need to do arthrogram because the blood itself in the hematrosis, the blood inside the joint, can actually act as a natural contrast. Sometimes we will do a CT scan with a 3D reconstruction of the glenoid to assess the bone loss when there is any severe bone defect that we can see on the MRI or the radiographs, or sometimes we do from the get-go straight away if the patient comes to us with, like, for example, more than 5 to 10 times of dislocation. So after the first time the shoulder is dislocated, will it happen again? This is a very common question we get from the patient. Well, overall, the incidence, if you are young and active, is about 80%. So if you are less than 20 to 25 and you're a young active patient, we strongly recommend that we do the surgery. The reason we want to do the surgery is because we want to reduce the recurrence rate. And by reducing the recurrence rate significantly, we can alter the natural history. And so studies have shown that by doing the surgery, stabilization surgery from the first dislocation, we can reduce this rate significantly. Dislocation arthropathy is what happens if you leave the shoulder unstable and the patient comes back with more than 10 times of dislocation. Their risk of getting osteoarthritis of the shoulder when they are old is significantly higher. And therefore, a surgery can reduce the risk of recurrent instability, and also it can prevent the patient from getting this osteoarthritis when they are old. This is a case example of a patient who has developed dislocation arthropathy. So it's a 62-year-old man. He had more than 10 times dislocation when he was younger and now presents with severe pain and stiffness affecting his sleep. On the radiograph, you can see that there's a goat's beard deformity with loss of joint space on the radiographs, and this is advanced glenohumeral arthritis. So he ended up having a anatomical shoulder replacement done, and this is him at 4 weeks, quite happy with the results. So in terms of stabilization procedure, traditionally it was done by burning the soft tissue around the shoulder with a red hot iron, and this was described back in the days of Hippocrates. Bankart procedure is the most common surgery we do nowadays. It was first described as open surgery back in 1978, but nowadays we do it arthroscopic, i.e. keyhole. So he described the detachment of the anterior capsular labral complex from the glenoid as an essential lesion. So essentially, it's like you're sleeping on the hammock and one side of the hammock has detached, and this is essentially what happens when you have a shoulder dislocation, and therefore the humerus wants to dislocate out from the socket. So the general principle of us doing a Bankart repair is to reattach this labral complex and also to retension the inferior glenohumeral ligament. Nowadays, we use suture anchor to repair the labrum, and the recurrence rate after we do arthroscopic Bankart repair is very low. The diagrams on the right side, you can see the evolution of the suture anchors that we have used. We started off by using a metal, and we transitioned that to a polymer, and nowadays we do what we call all suture anchor, which means that there's no solid anchors inside the bone. It's just a ball of suture that coils up and provide equal strength to a solid anchor. We usually do the procedure either in a beach chair position, which is with the patient with a semi-recline, or we do it in a lateral position. And this has the added advantage of being able to put some weight to track the shoulder to allow us to open up the space when we do the surgery. So we started off by identifying the bony landmarks after cleaning and draping. And then we first start off with the standard posterior portal to visualize the joint. And then we establish our anterior portals to work on the shoulder. So usually we have about 3 porters. Sometimes we can do with one single anterior porter, but suture management can be tricky in this scenario. We start off by looking for any additional pathology, such as a small bony band cut, a loose bodice, or a slap tear, which sometimes can happen in shoulder dislocation. And then what we want to achieve at the end of the surgery is to create this capsular labral bumper that stabilizes the shoulder. And usually we use more than 3 suture anchors because studies have shown that if you do less than 3, there's a higher chance of recurrence. At the end of surgery, we want to see that our humeral head is centered over the socket, over the glenoid, and there's no drive-through of the space that we can see. This is a video of what we do when we do arthroscopic band cut repair. So this is me coming from behind. So on the left side, you can see the humeral head. On the right side, you can see the glenoid. And you should be able to see a labrum at the front, but you can see the labrum is torn off and it's retracted medially. So you can't really see the labrum now. And it's retracted all the way to this corner here. So this is what we call an abscess. So basically, it's like a parietal sleeve avulsion that has gone very, very medial. So we start by establishing our anterior porter. So our knife coming in from the anterior, trying to establish that porter. Okay, and then we have this device called the radio frequency device, and this basically just debride any frayed or unhealthy tissue so that we can have a better view of the shoulder. Okay, after we establish our first porter, as you can see here, we will start to establish our second porter. So like I said, we usually use 2 anterior porter to repair the labrum. And then we introduce this device called the liberator. Basically, this is like a sharp instrument that helps us to free up the adhesion. So what happens is when the labrum is torn chronically, it will want to scar down to a non-anatomical position. And after we liberate it with that device, we want to see whether we can use a grasper to try to pull it back, whether there's enough excursion for the labrum to come back onto the glenoid. So sometimes we switch our scope to the front. So this is our scope coming from the front. You can see this is the glenoid here, the socket, and the ball is on the right side here, the humeral head. And this is the torn labrum. You can see that it has actually torn off and moved all the way medially. And again, what we're trying to see is we want to see whether we have released this labrum sufficiently for us to pull it back and repair it anatomically onto the glenoid. Okay, so once we have liberated enough, and as you can see here, we are able to pull it all the way back to the front. And this shows that we can actually repair it now without too much tension on the labral tissue. Okay. Subsequently, we pass our anchors into the bone. So these are the anchors going into the bone. And we use a special passer to pass our sutures that comes out from the suture anchors. And we want to tie the capsular labral complex down and create what we call a capsular labral bumper, as I shown earlier. So this is coming towards the end of our surgery. You can see we usually use about 3 anchors. And at the end, this is what it should look like. You can see a big bumper at the front of the socket. So this is, again, what it looks like, a bumper that prevents the humeral head from gliding out. Okay, so in conclusion, not every patient who has a shoulder dislocation requires surgery. But if you are young and you are active, you do sports, especially contact sports, early surgery will definitely benefit you, and it can reduce the rate of recurrence, and it can reduce the risk of you developing shoulder arthritis in the future. Conservative treatment is reserved for those group of patients who are, for example, old, less active, and if you are young with a muscle patterning, i.e., the video that I showed earlier where the patient has got a painless dislocation, these are the patients who should try physiotherapy first. So that comes to the end of my talk. I'm happy to answer any questions that you guys have.
Thank you. Thank you,
Thank you very
Dr.
much.
Toon. So also just a reminder, if you have other questions, right, you can actually list down under the Q&A tab. Okay, so I do have some questions wanted to check, like what caused shoulder dislocation? Is there any particular people that is actually very high risk of recurring? So like for example, those sportsmen, right? They always soccer player and all those. So are they a very high risk And usually, if let's say they dislocate a few times, right, will that cause a very serious damage?
Yeah, so shoulder dislocation can actually happen to any one of us, but there are certain patients who are predisposed to have a higher risk. So, for example, patients who are born to have very lax ligament, we call them ligamentous laxity. Patients who have, for example, abnormal collagen formation when they are born. So these patients, for example, Marfan's or Ehlers-Danlos, they do have a higher risk of getting dislocation. And you are right. If you do contact sports, for example, if you do rugby, basketball, football, these sort of sports, we do see a higher chance of you getting a dislocation just purely from the fact that it is the mechanism of the sports. And once you have a first-time dislocation, like I mentioned in the slides, if you are young and active, the chances of you getting a recurrence is extremely high. And the only way to reduce this recurrence is to do something about it, to alter the natural history so that you don't have as high a recurrence in the future. But we do have to be aware that there are some patients, for example, those that has got muscle patterning. So if you have born with some abnormal muscle coordination or abnormal muscle control, you do sometimes can get a generalized laxity of your shoulder, which might not cause you any symptoms, and they can do it as a party trick that they can just dislocate it. This sort of patient is best not to offer them surgery at the get-go because you will stiffen up their shoulder unnecessarily and they can run into future problems.
I see. Thanks for sharing the valuable insights. So I also know that you're in a hurry of time. So right now, if let's say you still have further questions, do email to Dr. Toon at hcortho.sg, and HC Orthopaedic Surgery is located at Mount Elizabeth Novena Hospitals. And thank you, Dr. Toon, for sharing all the information, all the knowledge to all the doctors. Thank you for today.
Thank you, Angel. Thank you, everyone.